The tremors in Parkinson's disease typically is described as rest tremors, meaning that it's worse when the patient is more obvious when the patient's limbs are held supported against gravity. So how would you examine for tremors? You just sit the patient in a comfortable chair with armrest, and the arms are rested on the armrest, supported against gravity, and you watch out for the rest tremors. These are actually quite slow tremors, about 3 to 4 hertz, involving the thumb and the index finger. That's why it's sometimes called a pill rolling tremor. If you don't see it when the patient is just sitting at rest like this, you can distract the patient by asking them to close their eyes, count backwards from 100, or you can ask them to walk up and down, because sometimes it's more obvious when the patient is walking. Yeah. Not to forget that the tremors in Parkinson's disease, well, very often you see them in the hands, but they can start anywhere else in the body. They can start in the legs. You can also see these tremors in the chin, in the tongue, in the voice, but typically they don't involve the head. That means you don't see a Parkinson's disease patient having no tremor or a yes tremor. One misconception is that if you see postural tremors or action tremors, sometimes you feel, oh, maybe this is not Parkinson's disease. But if they seem to fulfill the criteria and they do have a little bit of postural tremors, it's not unusual. Yeah? This is part and parcel of Parkinson's. Now, moving on to rigidity. Rigidity in Parkinson's patient is uniform throughout the range of movements, unlike the clasp knife rigidity of a patient with spasticity. So to examine that, you would put the elbow through the whole range, the wrist through the whole range, and you can do the same thing for the legs. Again, you can be enhanced if you feel that the patient is sort of voluntarily contracting its muscles and you can't examine properly. You can enhance it by asking the patient to do some mental tasks. And bradykinesia refers to the slowness in movements. And for this, you would normally ask the patient to do this. Repeated movements, not just 2 or 3 times. You ask them to keep going and going, because eventually, if it's a mild case, they will slow down. They will eventually grind to a halt. You can do this. You can ask them to turn the hands around like this. And in the legs, normally you ask them to tap and see whether they eventually will grind to a halt. For the severe cases, it's very obvious. It's very small amplitude and very slow. Sometimes postural instability is sort of mentioned as part of Parkinsonian sign, but just to note that it's not a prominent feature in early Parkinson's disease. And you can test this by asking the patient to stand with his feet apart. Tell him to steady himself, that you're going to tuck him over the shoulders backwards, and that he can take a step backwards in case he feels like he's about to fall. So you just go like this, 1, 2, 3, and pull him and see whether he can right himself properly. Other motor features that they may present with would be the gait disturbances. They get up from the chair very slowly. They have start hesitancy, meaning for the first few steps, they take a long time to just start up. Once they walk, then they have this shuffling gait, and they're sort of trying to chase their center of gravity forwards. Some of them have freezing. This is a particularly problematic symptom, because sometimes when they are about to cross the road or when they're about to just enter through the door, they just freeze, and sometimes they topple over because of freezing. Most of the gait disturbances occur late during the disease process. This is a common misconception, that the motor features in Parkinson's, being a condition which has no sort of structural lesion on the CT, some people might think that it should be symmetrical, but it's not. It is actually asymmetrical during onset, and if you follow these patients up, they normally remain asymmetrical for many years. And the motor features normally respond very well to L-DOPA in the early stages. When we say respond well to L-DOPA for our Asian population, normally when you reach L-DOPA of about 600 milligrams a day, they should show some response. If they don't, then this is a sign that tells you something is wrong, that this may not be Parkinson's disease. So there are many diagnostic criteria that have been used for Parkinson's disease internationally, but most of them incorporate this combination. It's a combination of the presence of the cardinal signs, that they must be asymmetrical at onset, and that they must respond well to L-DOPA during the early stages. So secondly, if you feel that this patient has Parkinsonism, then we move on to see whether they have any atypical features that tell you that this is something else and not Parkinson's disease. This is because there are many conditions which may mimic Parkinson's. In the elderly, the atypical Parkinsonian syndrome that we have mentioned, do ask whether the patient is on any neuroleptics or antiemetics, drug-induced Parkinsonism. Cerebrovascular diseases, multiple strokes can cause pseudo-Parkinsonism, and this mainly presents as lower limb Parkinsonism. They're usually spread in the upper part of the body. Patient who has had encephalitis may be left with Parkinson's features. A patient with hydrocephalus, recent head trauma may also have this. So there are many conditions that we have to rule out. And in the young, don't forget that Huntington's disease in the young usually starts with Parkinsonism first, and later on they develop the usual dementia and the chorea. Wilson's disease, dopa-responsive dystonia are all the things that we have to think about if it's a young patient. So I guess for my presentation, this is the only slide which I feel is really very, very important that you have to remember. And these are the red flags for Parkinson's disease, the no-nos. So if a patient walks to your clinic, I have symptoms of slowness, tremors for about a year. Ask the patient whether they have any of these features. They should not. They should not be falling all over within the first 1 or 2 years. They should not be demented, have visual hallucinations, have swallowing problems, the speech is involved. When you examine, there's limitation of extraocular movements. These are all abnormal. Yeah, shouldn't have early postural hypotension, bladder instability. And if you have followed these patients up, and after some time you note that sort of they have become wheelchair bound within 3 years, 4 years, this is also abnormal. Yeah. If they don't respond to your treatment with levodopa, it's very symmetrical from onset. And when you examine, you find pyramidal signs or cerebellar signs or apraxia. So this tells you that we are dealing with something else. I feel that it's important just to highlight this because, firstly, we mentioned that the mimics for Parkinson's disease, some of them are curable. So it is important to sieve these conditions out very early in the course of the disease. For instance, if you miss Wilson's can actually progress to give you permanent neurological damage and even death. Hydrocephalus is so easy to reverse, yeah? Just insert a shunt. Then you might say, if the patient eventually turns out to have one of those atypical Parkinsonian syndrome, but there's no cure and the prognosis is even worse than Parkinson's, so what's the point of trying to differentiate them? But that's because for each of these atypical Parkinsonian features, disease, they have their own combination of complications that we want to watch out for. Some of them have early bulbar problems. Some of them, you know, they are going to fall very easily. So you know what to advise the patients and what to watch out for before they get into problems. And even if you feel that the patient has typical Parkinson's disease, you've been following up for a couple of years, do regularly look for all these atypical features, because sometimes early in the course of the disease, it may appear to be very much like Parkinson's, but later on, as you follow up, the atypical signs may then appear later. And finally, if they have fulfilled both of these, then you will move on to see whether they fulfill the diagnostic criteria. This is actually not very important to remember. There are so many of them that they are being used. This is just an example by Khan. This is another example by the UK Parkinson's Disease Society Brain Bank criteria. Just to remember that most of them include the 3 cardinal signs, that they must be asymmetrical at onset, they respond to your treatment, and you have looked for atypical features, there is none. That is all that we need to remember, actually, for the diagnostic criteria. I think maybe I'll skip this because of limitation of time. So moving on to investigations, if the patient is of the correct age group, he comes in his 60s, he has no atypical features, he's responding to treatment, you do not actually have to investigate this patient at all. Yeah, it's understandable that sometimes patients say, you tell me I have such a serious condition as Parkinson's, there is no cure, you don't send me for an MRI of the brain, no blood test. But you have to sit down and really explain to them that the diagnosis is actually clinical. Yeah? There is no single investigation which can replace the clinical diagnosis. But if the patients are young, if you feel there is something wrong with the features which don't fulfill the criteria, then please feel free to refer these patients to a neurologist or a movement disorder specialist. So in summary, it's just to highlight that Parkinson's disease is progressive. There are motor and non-motor symptoms. The diagnosis is based on only clinical features. And we should try and sieve out the alternative diagnosis early, because some of them can be treated very well. And that on follow-up, you should continue to survey for the atypical features even a few years down the line from onset. Thank you.